very well capable of controlling that and help the children not go into a blinding condition like RD, CNVM, and glaucoma. So let's go into the theories and etiopathogenesis of myopia progression. That is my topic today, understanding the myopia progression. So we all know this, that education, economics, electronics, environment, along with genetic factors, go on to that myopia, or the prevalence of the myopia increases because of all that. But how exactly does it happen? So first and foremost, there were animal models for conducting the to study the myopia, how it progresses actually. They were form-derived myopia model and lens-induced myopia model, where you put a diffuser or a lens in front of the eye, and they study how the defocus actually affects the axial length elongation. So if you put a minus lens in the developing eye on chicks or tree shoes or monkeys, they noted that axial length elongated because the rays were focusing behind the retina, and that gives a stimulation, and vice versa if you put a plus lens. So that is the first theory, the feedback emmetropization. That is how it came, the first theory, along with all the studies. So when there is a visual stimulus defocus, for example, it can be myopic or hyperopic, but in myopic cases, it is hyperopic defocus. There produces a retinal response, and that leads on to a communication to the sclera, triggering a remodeling on the sclera, which affects the axial length elongation. Similar action is seen when there's an accommodation lag. It produces a hyperopic defocus as well. So that's the first one, and that is where the role of low-dose atropine comes into being. It has actually dual mechanism of action. So it has an action on the retina as well as sclera. Retina, where it targets the neurochemical cascade to just inhibit so that there's no tendency for axial length elongation. And on the sclera, it's actually affecting the glycosaminoglycan synthesis, which affects the extensibility and fibrous component. So that's the basic action, but further, Dr. Gigi Augustine Madam will be speaking more about it. The second theory is the peripheral hyperopic defocus. So what happens when a basic concave lens is put in front of the eye? The central rays are correctly getting focused on the retina, but what happens in the periphery? The peripheral rays are getting hyperopic defocus, and this has been very well studied by Earl Smith's experiment is proven. So that is where the novel spectacle lenses are being developed to counteract that. So the hyperopic defocus as being controlled by the novel specs while maintaining the clear central vision. More of that which our dear Monisha Madam will be speaking about. The third theory is the role of accommodation. That is what I said in the beginning of the hyperopic defocus. So when there is an accommodation lag, it provides a stimulus for hyperopic defocus. Accommodation lag is equal to hyperopic defocus. Again, it goes all to that neurochemical cascade where it the retina communicates to the sclera, and that provides a stimulation for axial length elongation. So when a child who's got already an accommodation lag does a lot of near work because various factors as shown here, it will again lead to axial length elongation. So that is why the importance of lifestyle modification comes into play. And also there's a big role on reading in bright light. So what happens in bright light is that when the child is reading a book in a bright light, meiosis happens, thereby increases the depth of focus. So that can actually compensate for the little bit of accommodation lag that the child already has. So that is again another importance of the bright light. The fourth and the last theory is the light dopamine mechanism, where a quantity and the spectrum of the light has a very big impact on the axial length elongation. So when a particular type or amount of light comes into the retina, the intrinsic photoreceptor retinal ganglion cells gets activated and dopamine just releases. And that dopamine release acts on axial length reduction along with increase in choroidal thickness, and that is where the novel treatment right now comes into play. The light therapies, red light and the blue light has come into play, along with the importance of outdoor activity Here you can see the outdoor light is around 10,000 lux versus the indoor lux is around only 500. So you can't even compare the benefit of outdoor activities. So nevertheless, whatever it is, when you see a myopia case, these three cardinal things should be counseled to the parents as well as children. The importance of the increased outdoor time, at least more than 14 hours plus per week. High indoor ambient lighting while reading, as well as frequent break. 20-20-20 rule is a must. It should be followed very religiously. So the billion-dollar question, when to intervene? So that is by risk stratification first and documenting a myopia progression of more than 0.5 diopter per year. So high risk means when there's a larger baseline refractive error, younger the age of onset, who has a parental refractive error. Basically, if the both parents are having a myopia, there is a 3 times chance for progression as well as prevalence for the child, and also very poor visual environment situations. So you understand what is, you stratify the children, identify if it is a high risk or low risk, and follow up documented progression more than 0.5 diopter per year, we start the intervention. What are those interventions? It can be pharmacological or optical interventions and more. So that will be dealing with right now.